Hello, my name is Nelson Vergel. Welcome to IFARA's webcast on metabolics and cardiovascular complications of antiretroviral therapy. We have, including myself, three panelists tonight: Jeff Taylor, Dr. Valeriana Morosa, and myself. I'm going to let them introduce themselves before we continue with discussions on the topics presented at the 2007 CROI. Jeff?
My name is Jeff Taylor. I'm from Palm Springs. I'm a longtime activist and living with HIV for 25 years now, I guess. And a member of the ATAC Drug Development Committee, also serve on a number of advisory boards, was on the community constituency group of the ACTG for a long time when metabolic complications first came to the fore, and was there at the beginning when they first began to study these things.
Well, what's ATAC, I'm sorry?
ATAC, is the AIDS Treatment Activist Coalition. It's a coalition of treatment activists who work on advancing treatment and research in HIV.
Yeah.
I'm Valerie Amorosa. I'm from Philadelphia. I am Chief of Infectious Diseases at the Philadelphia VA and work at the University of Pennsylvania as well. I work in clinic with people who are HIV infected, doing HIV care, hepatitis C care, and primary care.
And I'm Nelson Vergel, also a long-term HIV positive patient, over 22 years, and an activist since a long time too, member of ATAC, the AIDS Treatment Activist Coalition, and also do a lot of work lecturing around the country and moderating a few websites on the internet. So let's start. There are a few studies that were presented on Monday in the oral sessions on metabolic complications in HIV. As we all know, we've had complications since, the first day. We have wasting syndrome since the start of HIV. And by 96, 97, we started seeing problems with lipodystrophy, high cholesterol, triglycerides, blood sugar, body changes, lipoatrophy or fat loss under the skin, and even some bone loss. And it's been a few years. We have now, 11 years of accumulated experience. And this year we've had a few studies that clarify some of the roles of not only HIV, but the different medications. The first study I'd like to bring up to the panel is the presentation number 38, Metabolic Outcomes of the ACTG 5142. It's a study that actually compared the combination of Kaletra with Sustiva without any nucleosides, another arm that had Kaletra and nucleosides. The nucleosides arm included ACT 3TC or tenofovir 3TC, and another arm that had Sustiva and nucleosides, also either ACT or tenofovir. The main findings were that the Kaletra plus Sustiva arm without nucleosides had a higher amount of cholesterol and triglycerides. And surprisingly, I think it's the most surprising thing, at least to me, is that the Kaletra plus nucleoside arm had a less incident, lower incidence of lipoatrophy or fat loss under the skin, as has been correlated to facial wasting, than the Sustiva nucleoside arm. And I just want to open it up to the panel for your thoughts on this really intriguing study.
Well, I think also I thought that was surprising, and I think talking to people at the conference, a lot of people also were a little bit surprised by that. And I think I would sort of look at those results with some caution. There were many endpoints in this study, and in this arm of patients who got Sustiva together with two nucleosides, they didn't lose a lot of peripheral fat. It's just that sort of this definition, which is a relatively arbitrary definition used in the study of lipoatrophy, saw more patients with this lipoatrophy definition than in the Kaletra arm. The question is does this really even fit with what we encounter? I haven't personally really felt that Sustiva is a drug that is associated with fat wasting, and certainly not with facial lipoatrophy, facial fat wasting. So I think that probably it's intriguing, certainly. Maybe there's something going on molecularly that we really haven't thought about with this drug. But I don't think that sort of coming away with this, when I sort of make a decision with a patient about a drug to use, that I'm going to say, oh, let's not use Sestiva. We're worried about, wasting of fat in the arms and legs, because I think it's they have to look at this data a little bit more, tease out the role of the nucleosides a little bit more before we really are going to sort of say that this is a real, genuine concern with Sestiva. I mean, it's a drug we sort of use so often.
Jeff?
Well, it'd be interesting to see what the patient and clinician assessment was of the fat loss and whether or not that correlated with the other findings.
Yeah.
Because that's kind of the bottom line. It's so subtle in so many cases that bottom line is how do they feel about it?
Yeah.
And that should be the guiding principle, I think.
I think that also the study actually pinpoints that maybe those that were taking ACT, of course, had more of a lipoatrophy than tenofovir or Viriad, and that's in agreement with what we've seen in the past. So, or maybe, like you said, there may be a molecular or even an effect of Sestiva on ACT intracellular levels we don't know about. Or maybe this is just a matter of just looking at the data a lot more closely and probably just finding another conclusion later on. So it's an intriguing study. I don't think we can make that many conclusions about it. I think we'll probably hear a lot more about it in an upcoming meeting this summer in Sydney, the lipodystrophy and adverse events meetings there. Well, we're going to switch now to oral presentation number 40. This is a very interesting presentation because it actually looked at the use of polylactic acid. It's a facial filler approved in the United States, in Europe, Canada, not Canada, I'm sorry, in a few developing countries and developed countries for treating facial lipoatrophy. This is actually an Australian group that did a study and actually performed for the first time since I've known work in lipoatrophy, CT scans of the face to actually find out whether or not this product increased the thickness of the cheeks, and they also had a questionnaire for patients to fill out about how they felt about the way they looked after 4 injections of this product. The finding actually said that the patients felt that they looked a lot better. Their facial lipoatrophy was improved. But however, the CT scan results did not show an increase in volume, in facial volume per se. 60% of these patients had severe facial wasting. That's also very important to bring up because I think in those cases it may be a more difficult case to treat. And it seems like the Australians in this study used a little bit of a different technique than that used in the United States. They injected under the skin instead of muscularly in the face, which is the way it's used in the United States. So I just want to ask the panel what your thoughts are on the use of polylactic acid in this study and the results that show that may or may not have an effect on volume.
Well, it was a little disheartening because we were all hoping that it would be a home run and we have clear clinical evidence supporting, the big issue in these states, of course, is reimbursement for this because it's not cheap. Patients desperately need it, and it's something that requires a series of treatments. It's very expensive, and getting it reimbursed has been a huge issue, and this doesn't really provide us the data that we were hoping for to do that. That said, I think you're right that in severely wasted people, 4 treatments is not going to be enough. I think 6 to 8 is what's required in severely wasted patients. So perhaps they didn't do it long enough or have enough treatments or correlate the gradation of wasting with the number of treatments given to get the optimal results.
Yeah, I agree. And, I think that this sort of hard endpoint, we always love to have these hard endpoints, but really going back to what you said about, if the patients felt like they looked better, that, this is not necessarily a cosmetic issue at all. It's almost like a reconstructive issue. And so, it is, I was disheartened also by sort of the CT evidence, but on the other hand, the sort of outcome maybe should be how people feel about how they look afterwards, and that would be sort of something positive to take away from that. And then also I agree, the numbers of injections and the methods, who knows if it's needs to be done differently.
Yeah, just want to also make sure that people understand Sculptra polylactic acid is one of the 2 options approved in the United States. There's actually another product just approved recently called Radius, and there are a few other products used in Canada, Mexico, and Europe that are more permanent, like bioalchemate or PMEA, and even silicone micro droplet injections here in the United States off-label. So there are other options too that clinicians are using permanent solutions. I think polylactic acid is perceived more as a non-permanent solution, which may be applicable actually for people that have moderate to more mild cases of facial lipoatrophy. But in this case, in my point of view, 60% of patients had severe facial wasting, and I do have a strong bias for the product in those cases. We've seen people complaining that they need too many injections over 7 sessions. These are sessions that are done usually 3 weeks apart. And luckily, we have the company in the United States have actually provided the product free of charge for those that have an income of under $40,000 a year, and that's actually helped a lot of people. But we still have a lot of problems trying to get reimbursement, and people, insurance companies, and different third-party payers to pay for this option, since it is still perceived as a cosmetic issue and not, like you said, a clinical reconstructive issue. This is actually a problem that was originated by 2 drugs. So people are actually wanting to look healthy again, and I think it goes beyond the cosmetic aspects that some insurance companies don't want to pay for. Mm-hmm. Anything else that you want to add on this? No?
Yeah,
Can we move on?
that issue of, the drug company's paying for the injection, but the actual administration fee is what ends up being expensive for people to pay for.
Well, I think the analogy to make is there's no argument that women who have radical mastectomies get breast reconstruction, and shouldn't it be the same for people who lose their faces as a result of HIV treatment?
Let's move on to the next study, presentation number 41. This is a very interesting study that actually compared people that were enrolled in the SMART study. This was an treatment interruption study that actually found out that those that were in a continuous treatment arm, meaning they were taking their HIV medications without stopping, and there was another arm where patients were stopping based on their CD4 cells, and they were starting and stopping depending on that. They found a little bit of a higher, I don't know how much higher, but a little bit higher incidence of cardiovascular disease in those patients that were stopping treatment. Just want to open the discussion to both of you, see what may or may not explain. By the way, 40% of these patients were smokers. That also is a huge risk factor. And of course, heart and HIV may be also implicated here. What do you think may or may not be explaining the differences between the 2 arms here when it comes to higher incidence on cardiovascular disease?
Yeah, I think, it was surprising when this data first came out. We thought that, well, at least when patients interrupt treatment, they're going to have less cardiovascular disease. I think that this point that you bring up about the smoking is really important. Clearly, and there was a lot of posters at the meeting that also showed that the real major risk factors for cardiovascular disease in people with HIV are still the traditional risk factors: smoking, diabetes, hypertension, family history, high cholesterol, all the things that primary care doctors have to really sort of focus on. And the HIV-related factors, meaning use of protease inhibitor a long time, are perhaps contributing, but less sort of vital. And so I think that, sort of primary care is important. That being said, I don't know. It's possible that there's sort of inflammatory factors related to reemergence of the virus that sort of change the inflammatory milieu in the body, and that, that would predispose potentially to a sort of an artery that has atherosclerosis in it, meaning, an artery that's sort of a little bit clogged, getting a little more clogged when you sort of allow the virus to grow up again. That's one potential explanation. I know that the cholesterol levels sort of changed in the way you might expect when people stopped nevirapine, which tends to have a positive effect on cholesterol. Their cholesterol went up, and that's sort of another potential explanation for some of the patients. But I don't know that I really completely understand the reasons.
Well, and another thing to to think about, perhaps in the context of the SMART study, is that they were letting people get sicker and have lower CD4 cells. And I think in retrospect now, the guidelines have changed somewhat, and people wouldn't stop therapy at such low T cells counts, and maybe that could be a factor as well. And if they redid this study at more optimal levels, that might not be such an issue.
Yeah.
I think we're going to take a question from somebody that just sent it in from the internet. As you know, there's a study called the FRAM study. I forgot what it stands for because it's a long name. That was presented, 2 years ago, I think, that actually concluded that accumulation of fat in the visceral area, or what we used to call the Crixie belly, then we call it the protease belly, so I don't know why we're calling it lately, was not really different. The incidence was not different in HIV positive men compared to HIV negative men. And even, I think I remember that even they found buffalo humps in HIV negative men too, although they did not seem to be as big in volume as the HIV positives. So somebody's asking, what do you think about the FRAM study seeming conclusion that there are no significant differences between visceral adipose accumulation in HIV positive versus HIV negatives? That's another tough question there.
Well, I think that there's probably a couple things going on, and there's been a few more studies published since then to suggest that this sort of metabolic syndrome, which we talk about as an epidemic in the U.S., what is the metabolic syndrome? It's people who have fat accumulating in the belly associated with potentially diabetes or sort of an elevated sugar, cholesterol abnormalities, maybe high blood pressure, and then a risk for having cardiac disease. So this is really common in the U.S., and it's really common in people who have HIV. And many studies now are sort of showing that a lot of metabolic syndrome, lipodystrophy syndrome in people with HIV is actually probably metabolic syndrome that every other American or many other Americans have. But clearly there's sort of a different pattern also, and people who sort of really accumulate deep fat deep in the belly clearly started after they initiated therapy, associated with tremendous wasting peripherally. This lipoatrophy really doesn't seem to be the same thing as in the general population. So yes, these studies show this sort of metabolic syndrome overlap, but I don't know that you can necessarily say that there's not something that people with HIV on therapy get that looks really pretty unique.
Well, and I think something else that has come out is that there may be two different syndromes, and the fat loss and fat gain are two different things, and sometimes they happen together and sometimes they don't. And we've been lumping it all together under the term lipodystrophy, and I think we need to rethink that.
Mm-hmm.
Yeah, I think I have also a strong bias on this subject, since I've seen so many patients just blow up after they start heart therapy, and some people say, well, maybe the Norvir-based combinations are probably more to blame than not. Now we're finding out more and more that it's not all about the protease inhibitors like we used to think. The nucleoside backbone, SERID or ACT, had a very strong role. Actually, we're seeing more and more of the role of those two compounds in lipo accumulation, fat accumulation, and fat loss too. So now that we are removing those two compounds from the U.S. slowly, people are being switched slowly to tenofovir or abacavir, which is Schaich and Oviriat. We may be seeing the problem less frequently, or it may be going away slowly. I think we're going to see it a lot more in the foreign countries, in the developing world, because those people are exposed to these two nucleosides as we speak, and we don't know when tenofovir or abacavir are going to be available for international settings, so we don't know. So I do have a strong bias. I think my fear about conclusions like this are that therapies that are targeted towards lipodystrophy, like the upcoming approval, hopefully on Serostim, may have a problem with getting reimbursed by Medicare, Medicaid, or third-party payers if they look at this data and say, well, there's no difference, so this is not related to medications, it's not related to HIV, therefore this is more of a cosmetic issue. And yet again, like facial wasting fillers, we're going to have to battle that one too. So I come from that space of reimbursement, fear, trying to prove sometimes. And then now we're also seeing that some genetic factors too. Some people have some polymorphisms or genetic factors that make them more prone to having this body changes in the presence of protease inhibitors and SERET or ACT. So I just don't want this study to be generalized and used against people that are trying to access therapies and reimbursement for therapies. That's my only concern. And yet, you know, it is there, and it seems to be a well-done study. So,
Well, something I'd like to add to that discussion is the need for more research. I mean, these studies aren't definitive, and it speaks to the need for doing, and they have to be large studies. You can't do a small study on this. You have to do large longitudinal studies, and the prospective studies are good, but it's a constantly changing field. And they also need to be looking at people who did all the earlier drugs that perhaps cause problems and have large cohorts of those to see what's happening to these people. And unfortunately, it takes large numbers of patients and a lot of money, and the funding isn't there. We may never know the answers until the funding climate changes.
we're going to now shift our focus to from the body to actually bone density. There have been some studies in the past that have not concluded, but actually shown us that there may be some bone loss in HIV even before people start taking heart. So there's always a question, is this related to the HIV virus? Is this related to the medications? Or is this actually related to aging? Because as we age, most men and women tend to lose bone density. However, I don't think we've had a conclusion yet on the subject, but in this oral presentation number 42, we had actually therapy for increasing bone density. It's an andronate, which is, the brand name is Fosamax, used with or without calcium, vitamin D supplements. And the study actually showed, it's ACTG 5163, actually showed a 4% increase of bone density in 48 weeks, which seemed to be very close to the response in HIV negative people in previous studies. And it seems like almost a quarter of the people had osteoporosis at baseline, meaning they had really low bone density at baseline. So these are at least a quarter of these people had already problems at baseline. So I wanted to open the discussion and even talk about other options that people may consider when it comes to increasing bone density or even diagnosing problems with bone density.
This has been, sort of an emerging issue in the last few years, and it clearly seems like people with HIV, by the DEXA scan, which is sort of the test we do to determine bone density, have lower bone density than sort of people at the same age who don't have HIV. And the question really has been, as people with HIV sort of age, are we going to see a huge epidemic of people getting fractures, hip fractures, spine fractures, sort of the fractures that people get with osteoporosis? And luckily we haven't seen that yet, but I think that this is encouraging that we see that the alendronate, the Fosamax, works for osteoporosis in people with HIV just as it does in people without them, and that suggests that it's not some terribly different mechanism in terms of sort of our ability to treat it. Of course, it brings up the point, so should we be screening everyone? Should we be screening select populations? Even in the population at large without HIV, a really poor job is being done about screening for osteoporosis, so much so that people who actually have had fractures and obvious osteoporosis are not getting drugs like Fosamax and vitamin D and calcium. So, I think that it's sort of going to be a question over the next couple of years, who should be screened for osteoporosis. But clearly, people who have had fractures should be screened and should be treated, sort of at least at the very first.
Jeff?
Well, and I think it speaks to the issue of if this works in HIV-positive people as well as it does in negatives, then so do other things like using weight resistance training, diet, in terms of not just bone loss, but all the metabolic problems that people are encountering. I think people need to realize that everything applies to everybody. And they and their doctors, and hopefully the insurance companies will step forward and help reimburse for things like this, but in terms of providing exercise and nutritional counseling and that sort of thing. Because I think that's a big part of the picture, that we can't rely on a pill to solve every problem.
Yeah.
And also checking your hormone levels, because people that have low testosterone, which has been documented in HIV, or low thyroid function, tend to have more accelerated bone loss. But I do have, as an activist, issues with the fact that DEXA scanning, which is really a cheap, I was checking the prices on DEXAs, and in Houston we can get a DEXA scan for $100 if you get in the right place, a full body DEXA scan, which actually not only tells you how much bone density, how much bone do you have, but actually how much lean body mass and how much fat you have in every single part of your body. And I'm one of those that believes that everybody should get a DEXA scan. Of course, not everybody has access to third-party payment, and then compare that to every 2 or 3 years get another one just to see how things are changing. And DEXA is one of those things that I believe, of course, maybe not for everybody, but at least for maybe long-term survivors or older male and female, because we're seeing high incidence of bone density loss in males. I mean, we used to think, it's a female thing, postmenopausal. So I really think there's a lot more work to be done in educating clinicians and patients about the fact that this may be a problem, and waiting until you have a fracture may be just a long time to wait. And,
Well, and we should be vigilant, and again, this speaks to the need for longitudinal studies and looking at which drugs. There's been some question as to whether or not tenofovir might be a contributor, and we need to find out what the bad actors are. And it's really hard in the U.S. healthcare system because we don't have a unified healthcare system and record taking, and we may have to rely on European cohorts and other places to do a better job of that to find out what drugs might be contributing to the problem and adjust therapy accordingly.
Yeah.
At least it seems like calcium, vitamin D supplements, which are really cheap also, seem to work. Actually, there's an increase of, 2% only in the supplement group. So, that wouldn't hurt if you have no diagnosis, no testing, and exercise, weight training. Yeah. That's all you can do.
And I mean, there's been a couple of other studies. I mean, smoking is a big risk factor. And actually, there's even been a few that have shown sort of significant alcohol associated with decreased bone mass in people with HIV. So there's certainly a lot of modifiable things we can do. And I agree with you. Sort of the longer term, people who've had HIV longer certainly have decreased bone density. So that may be where to start with screening.
And now a very interesting study, number 43 oral presentation on the effect of D4T or SERET on insulin sensitivity and mitochondrial function in muscle, in HIV negatives, not positives. We've never had a study that actually showed that was actually looking into muscle mitochondrial toxicity or the connection between insulin resistance and mitochondrial toxicity. This is HIV negatives data, which is a good start. And also, as I said, the prior studies were always looking at fat cells, since that's where we had the most problems, loss of fat cells under the skin. So we're looking at the effect of D4T on fat cells. Any comments on this? Is actually a very beautifully done study, and yet we have a lot more work to do in this area. So, any thoughts on, how this study actually connects the insulin sensitivity, lowering insulin sensitivity? That actually D4T not only has an effect on mitochondria, which are the very tiny little energy factors in the cell that tend to be affected by this nucleoside, but also has an effect on how muscle cells process, actually help insulin do its job of storing sugar, converting into glycogen. So for the first time, there's a link in muscle cells, and I think it's very exciting. Anything you can add or comments?
Well, I thought it was exciting, but part of me wanted to say, well, but who takes D4T anymore?
Well, for the developing countries.
In the developing world, it's a huge issue, but and here, we need to look. It's a good start, as you said, but I think we need to look at the drugs that people are currently taking to see what's happening there, because people are still having glucose intolerance and diabetes, and it's not on D4T.
Well, we have 5 minutes left, and we've left probably the most important therapeutic talk, meaning talk about treatment of lipodystrophy-related fat accumulation in the belly, in the abdominal area, by a product called TH9505, a growth hormone releasing factor analog. It seems like this product, 2 milligrams a day, an injection under the skin. It's a Canadian company that actually performed the study with different centers in the US and Canada. They found 3 centimeter difference in waist size after 26 weeks, 15% increase in visceral fat, doesn't seem to have a problem or decrease in subcutaneous fat, did not seem to, unlike Serostim, increase glucose intolerance or glucose. And it also seemed to have a fewer problems with arthralgias and joint pain. So I just want to, I know Jeff, you know a lot about the drug and you've been in the study and doctor, so I'm going to leave it up to you guys to discuss.
Well, I'll just share my personal experience, having been in both the Serostim study for visceral adiposity, and then a year later, after having been off the drug, the belly came back and qualified again for the TH9507 study. And for me, they both worked equally well. I think it's a difference in dosing. The Serostim dose is actually fairly high. They start at 4 milligrams a day and then go to a 2 milligram maintenance dose. Whereas the beauty of the 9507 is that it's promotes your own body production. It's endogenous growth hormone as opposed to exogenous.
Can you explain what that means?
It means that your body you take it in the morning and it works throughout the day to help your body create its own overnight. Most of growth hormone is produced while you sleep. And so you take it in the morning, and during the course of the day, it stimulates your body to release it overnight, and it helps to burn the fat, which is and it does it very effectively. It took a little bit longer for me, and I think they're noticing this for most people talking to the study nurses at a couple different sites, and perhaps because it is a lower, more natural dose, it takes a little bit longer, but over the long term it seems to work just as effectively, and they're able to use it on people who have a little bit of insulin resistance even at the outset, so that's encouraging.
19% of patients at baseline had diabetes or glucose intolerance, and that's actually an exclusion in the studies that were done with Serostim. So that's a good thing.
Yeah.
Do you have anything to add on this one?
Yeah, no, that factor alone was very encouraging, that it didn't produce the same glucose intolerance as the growth hormone.
I'm just concerned about, once again, about reimbursement. Who's going to pay for this if it gets approved? Serostim is very expensive. It costs $1,000 per milligram a month. So is this going to cost the same? Is our insurance company going to pay for this? Are they going to look at this as a cosmetic issue, or are they going to look at this as a clinical issue? There's some studies that have shown that people with higher amounts of fat in the abdomen, in the internal side of the abdomen, tend to have a higher incidence of cardiovascular disease. Those are HIV negative studies, and yet I don't think there's a conclusive evidence for insurance companies probably to say, okay, we're going to provide this treatment so that you don't have future problems with cardiovascular disease. So once again, I'm always concerned about reimbursement and access after something like this may or may not get approved, and so it's going to be a challenge again.
Well, and there are other issues besides just cardiovascular. There are more immediate concerns. I found I had trouble sleeping on my stomach. There was so much fat in my belly that affected my diaphragm, and I found myself breathing more heavily. I mean, it has more immediate effects above and beyond just the possible
and
cardiac
some people ask me,
implications.
how about exercise and nutrition compared to this? Can we actually decrease the lipodystrophy-related fat gain with more exercise or lower carbohydrates in the diet, or with drugs, diabetic drugs like metformin, glucophage, which we have some data on? How does that compare to this? So it's definitely questions that we're starting to get from different patients. I don't have access yet. Can I control my fat gain through other more non-pharmaceutical based options? Any other things to add? So I guess this is the end of the metabolics and cardiovascular complications panel discussion, and we'd definitely like to encourage you to stay tuned for the next panel discussion, and we thank the panelists for being present and helping us out digesting the information for the community. Thank you very much.